Good morning, everyone. Welcome back to our next episode of ACS Cans Coffee Club. I'm Doug Flora. I'll be your host today. Most of you guys know me by now. If you don't, I'm the Executive Medical Director of Oncology Services here at St. Elizabeth in Northern Kentucky. We have a fun program today, hopefully instilling a little bit of hope in people and talking about some of the depth and breadth of change that we're seeing in the world of science of lung cancer. So we've got a couple great guests today. I'm excited to have both. We'll start with Devon Adams, who is on the policy side of things. He's going to help us walk through some of the issues that we're dealing with biomarkers and disparities in care, as well as hopefully some time to comment on the advent of virtual health with the global pandemic pushing us to our computers more and more. Our other guest is Dr. Mark Socinski, who was an inspiration to me young in my career. And I don't want to age you, Mark, but I can remember seeing this world-class lung cancer expert teaching me when I was a fellow. And I'm now 50, Mark. So that's really the span of your career and what you've contributed to our field is fantastic. And I hope to touch on some of those because some of the things that you've led over the last 10 years have changed the way we even think about lung cancer, much less treat it. So why don't we start with Dr. Socinski? He's Executive Medical Director at AdventHealth Cancer Institute now. So he's moved a little bit to the admin side like me. Obviously, you can have an outsized impact now because you've got control of budgets and hundreds and hundreds of people that are cancer fighters out there, many of whom are like the folks that you see on this call. And so we have a wide audience. We've got PharmDs and pharma reps and lung cancer advocates and legislative people and clinical people. So I thought maybe we would start with a little introduction to lung cancer then and lung cancer now. You've been there since the onset of the earliest medications in lung cancer. We were talking offline about that. Maybe talk about perspectives, because very few people have 30 years in lung cancer experience from the original days where you were sort of rubbing things together and hoping they would stick, and now much more targeted therapies. It's got to be amazing to see the progress in your field.
Yeah, Doug, thank you. It really is amazing. When I started in this business in the early 1990s, I can show you editorials written at that time, pro and con, was lung cancer or is lung cancer a treatable disease? Some people arguing, yes, it is treatable, but some arguing, no, we don't have evidence that treatment really changes the outcome in this setting. And it really wasn't until there's a famous non-small cell collaborative group meta-analysis that was published in the British Medical Journal in 1995. So it was really 26 years ago, where in the meta-analysis in stage 4 disease, there were 9 trials that randomized patients to supportive care alone. So kind of, best supportive care, no active treatment, versus cisplatin-based treatment, cisplatin delivered a la the standards of the 1980s, where we had no effective antiemetics and these sorts of things. Very tough treatment, and it really showed a statistically significant, clinically meaningful in the sense that you got a foot in the door, that it changed the natural history of disease, and you could do something about it. It started to maybe chip away at the nihilism that was surrounding this disease, and still to a certain extent in certain sectors still exist in terms of the treatment of lung cancer. There was argument at that time that the survival benefits were very modest. Was it worth treating given the fact that there was a lot of toxicity and that sort of thing? Well, at the end of the day, when you start to look at symptom relief studies and maybe some rudimentary quality of life studies, that patients actually felt they did better with active treatment than best supportive care. I've always said there's nothing worse for your quality of life than uncontrolled cancer. That is the worst detriment to your quality of life. And then, Doug, if you just fast forward to 2021, where lung cancer has become the poster child for targeted therapies for immunotherapy. And again, we saw, and we should touch on this several times, in 2017, the greatest annual reduction in cancer mortality that has ever been seen in over the course of a year. And it was largely led by lung cancer and melanoma, 2 diseases in which immunotherapy certainly has made a major impact. So We've learned so much about the biology of the disease over 25 years. We've learned that whereas 25 years ago, it was kind of one size fits all. We alluded to ECOG 1594, where really didn't matter what chemo doublet you used, all the outcomes seemed to be the same. Maybe you chose one based on side effect profile and that sort of thing, but kind of one size fits all, where now the reality of our life in lung cancer is it demands as standard of care comprehensive genomic testing, particularly in the non-squamous population, but also to include some of the squamous population, depending upon other factors. And then we've had at least nine randomized phase 3 trials incorporating various immunotherapy strategies. All have led to FDA approvals of a number of different agents. And so, it's a very demanding management of these patients nowadays if you believe that it is incredibly important to get the right treatment to the right patient at the right time, in knowing what to do. And so whereas 20 years ago, I've always said you can kind of fall asleep at the wheel of lung cancer and get it right. Nowadays, it's a very different situation with the heterogeneity of the disease that we see. And this creates, in my opinion, it creates a lot of hope. I saw a couple of patients on Tuesday of this week, which is the day I see patients. And, I saw a woman who was about 70, who smoked for about 5 years, 30 years ago. So she's a kind of never or remote light smoking patient. And her molecular stuff was not done. It should be done today or tomorrow. I also drew a plasma-based test on her because I want to cover all the bases. But, the hope that I have for her is that she has some actionable genotype that can be treated with an oral targeted therapy. So these things we just didn't have 30 years ago. Nowadays, it creates, the sense of hope that you can really more precisely personalize therapy for patients based on understanding the biologic nature of their disease.
It's been fascinating to watch. I'll tell you, the paradigm was here. I was a breast cancer doc for about a dozen years, and we knew that targeted therapies with anti-estrogens work, and then Herceptin came along in the mid-2000s and just changed the landscape. And I can remember thinking how different it was in my practice of lung cancer versus breast, because in breast it had to be ER positive, PR negative, HER2 neu 3+, FISH positive, and now we've entered that era with lung as well. So maybe let's fast forward a few years, and we've unraveled this genome a bit, both from a germline standpoint and somatic, which is what we'll talk about a little bit more here today. I just left Lung Cancer Tumor Board, and we're literally arguing about which exon is involved.
Yeah.
Whether it's an exon 19 or an exon 20, helping us determine which anti-EGFR we want to use. Are you testing biomarkers standard in all of your patients, even stage 2, stage 3s?
Well, yeah, that's a great question. We in the early stage disease, we do have a recent FDA approval for the consideration in patients who have EGFR, either exon 19 or 21 EGFR mutations, the use of osimertinib in the adjuvant setting. Of course, that is based on a disease-free survival benefit that's quite impressive. We don't yet know about the overall survival benefit. I have held the surgical population to the endpoint of cure, which is overall survival. Again, we don't know that yet. So there is a little bit of controversy there, but certainly in the early stage patients, we often do comprehensive genomic testing because, particularly in the node positive patients, because many of those patients will subsequently, unfortunately, relapse despite adjuvant chemotherapy. And you'll have that molecular information at the time of the development of stage 4 disease. In stage 4 disease, comprehensive genomic testing for all patients with non-squamous, selected patients for squamous, with squamous histology, is not an option. It is the standard of care. The FDA, depending on how you count them, I think there are about nine biomarker-associated indications for targeted therapies. And so in my opinion, just like you pointed out in breast cancer, there isn't a medical oncologist in the United States that would see a breast cancer patient and not know ER, PR, and HER2 status, right? And maybe there are others in breast cancer that I don't know about. I haven't seen a breast cancer patient since about 1991. I think things have probably changed since then. But in lung cancer, we kind of have, we've passed. I think we're the most genomically diverse from an FDA approval point of view. But you have to know all of these sorts of things, and maybe we'll get into the fact that that's often not the case in the practice of lung cancer across the nation. But yet it is so vitally important because of these drugs that are more effective than chemotherapy, more effective than immunotherapy. Many of these biomarker defined populations are not the type of patients who get great benefit from immunotherapy. So you have to realize, if, again, the job of the oncologist is to get the right treatment to the right patient at the right time. And you don't want to give them substandard treatment. You can't do that and follow that paradigm without comprehensive genomic testing at the time of initial diagnosis and getting that done as quickly as possible, so which way to go. I tell my patients, I essentially have 4 buckets of treatment. I have targeted therapy, I have immunotherapy alone, I have chemo plus immunotherapy, and then I have chemo alone, which is a very small proportion because most patients don't have contraindications to IO therapies. So my job is to get them in the right bucket initially. That may take an extra week or 2 if you have to wait for molecular testing, but you certainly want to make the right decision at the time of diagnosis and start down the right path for patients. And it does demand knowing all of those genomic alterations, as well as PD-L1 status, so you make the right decision.
Yep. I think that sets us up well to bring in Devon here. Obviously, we've just heard from a world expert. We should be doing this all the time. And I hope that most of us are, but I'll bet you can tell us that that's not exactly the case. And some of the things that are impeding our progress there in terms of lack of access to care, lack of equity. And maybe you can speak a little bit about what you're doing on the legislative side and working with ACS CAN on gaining greater access to these markers.
Sure. Perfect setup. As you know, you've alluded to how far this biomarker testing, especially in lung cancer, has come, but we also know that, patients who should be getting, biomarker testing and access to targeted therapy that's not always the case. And there are barriers that kind of exist in the way. ACS CAN has been involved in this work. And last year we took some work up and we released a landscape report and also our coverage analysis, really looking at some of the issues related to patient access. And some of the things that we've seen is that, insurance coverage is really important for provider uptake and patient access to testing. But we know that coverage, differs greatly across the multiple payers in the US healthcare system. And that in many instances, coverage for testing is failing to keep up with these, this remarkable innovation, and there are large coverage gaps. And we also know that, there also may be some provider institutional level barriers that may be, preventing clinicians from testing all of the patients who, need that guideline indicated biomarker testing. And unfortunately, we've seen that, not all patients benefit equitably from, access to biomarker testing. And there are notable, disparities that exist in some populations. And, it's important, especially as biomarker testing continues to take off, that these populations aren't left behind. I've seen some studies that show that, sometimes Black patients, Medicaid insured patients, and those with lower socioeconomic status face some disparities in biomarker testing. And I've seen the research, and it's around lung cancer and colorectal cancer, 2 really big areas where, the technology and the information is known that, when you have access to biomarker testing and you can get a targeted therapy, it really has huge impacts on, on patient quality of life and survival. So we really need to start working hard to dismantle these barriers to make sure that, every patient who could potentially benefit from testing and targeted therapy really, gets that access.
Mark, when you're talking about sorting these folks, the Harry Potter images come to mind, and you're trying to put the non-squamous EGFR positive in the Gryffindor clan and the Hufflepuffs, and it's a challenge clinically. And Devon, I'm glad that you're working on this stuff, because we have all sorts of people that we know we need this test on, but if they're underinsured or the copays are prohibitive, or if there's difficulty in access to care, sometimes you can't afford those delays. And this group probably gets that better than most, because a lot of cancer advocates are on here. But for Mark and I, a lot of times we have to wait 2 weeks to even send these things off if the patient's admitted as a hospitalized patient. Maybe Mark, let's talk a little bit more about the science for the crew here. So, going back to your original analogy and our tumor board this morning. So now it's critical that we would say this is, we have to know the MET status, we have to know the BRAF, KRAS, EGFR, this alphabet soup of things. But really what you're trying to do at this point is define specific and identifiable targets, so you can hit these patients with smart bombs instead of bunker busters. Maybe let's speak to the emotional nature of that, because obviously it's not just about the biomarker. It's about understanding that this patient has a 50% 5-year survival if they respond to these drugs. Or can you maybe take a second, a step back from the science, to talk about a person, a human being whose life was affected by having access to these tests, and how it changed the trajectory of their life and their family and their cancer?
Yeah, no, I can tell you two quick examples that have been so professionally gratifying. We had a lady in our practice who was diagnosed with lung cancer approximately 5 years ago. So you have to be suspicious that her lung cancer, if you're around 5 years later, there might be something not typical about your lung cancer. She had testing 5 years ago. Interestingly, she had a test for ALK that was immunohistochemistry, and it was negative 5 years ago. Nothing else was done beyond that. And 5 years ago at our institution, it was right before I came there, I would argue that at that time, the molecular testing was relatively rudimentary. This lady went through several different types of treatment, again, had lived 5 years. However, her disease, particularly in the liver, was resistant to all therapy. She had had multiple lines of therapy. And just as we were having a talk about transitioning her to hospice, one of my colleagues sent a plasma-based test on her. And it came back showing an ALK EML4 fusion. This was a lady who was transitioning to hospice, was on intermittent oxygen, borderline performance status, who basically got started on alectinib and has had the Lazarus effect. Yep. She literally got rid of her oxygen, got out of her wheelchair, and is now almost having a complete response in her liver. So the expectation was, the expectation on hospice is, your prognosis is less than 6 months. I would draw people's attention to how important it is to identify these patients, is that if you look at the ALEX trial, which compared alectinib to crizotinib in ALK positive patients, the median survival of patients on the alectinib arm is probably going to end up being somewhere in the 7, 8, 9 years. Okay, so you've gone from a prognosis of less than 6 months to this woman who's a grandmother, who has lots of life events to look forward to. What could be more gratifying for doing something like this? And then I saw recently a more recent patient, 34-year-old gentleman who was a workout freak, a health nut freak, never smoker, busy doing his job, but ended up, from being a gym rat and doing all of these great athletic sorts of things, not being able to walk up to his bedroom on the second floor, because when he got to the top of the second floor, he was short of breath. He had to sit down, and his wife finally said, you really ought to get that checked out. So he ends up showing up in one of our ERs with a big pleural effusion. It gets tapped. It's adenocarcinoma. Again, he's a never smoker and everything. His PET scan shows clearly stage 4 disease, and he ends up having a RET fusion on molecular testing. And the story that he told me was that, he was having difficulty lying down at night and going to sleep because he felt this chest pressure. And it was enough that, he still slept laying down, but it was noticeable and bothersome and getting increasingly bothersome. And he said, I took we started him on selpercatinib, and he took his first dose, and within 24 hours, that chest pressure that he was feeling was gone. And when I saw him, I usually see these patients about 2 weeks later, just to do a toxicity check on them. And this guy was back in the gym, back working full time. He goes, yesterday, I see patients on Tuesday. He goes, yesterday I worked 14 hours. And I felt fine. He goes, the question is, his question is, how long is this going to last? And of course, it's still early in the RET fusion story to really answer that definitively. But to your point, Doug, these are the sorts of stories, we all have them as oncologists, but these are kind of opposite ends of the spectrum. A lady that had been very deep into her course of lung cancer, where something was found even on retesting that's going to make a huge difference. And of course, this young man now enjoying a very nice response to his orally administered targeted therapy. This is why you have to know in every one of patients. And it's just as important to know whether it's there or not, because if it's not there, these are the patients that are more likely to benefit from IO or chemo IO sorts of strategies. That, there are a bunch of those too to consider in the appropriate patient. But those are just two examples of why molecular testing is important, and why it's important over the course of the disease too, because many of us do have these patients that may not have been comprehensively tested. Let's face it, RET fusions, the FDA just approved these drugs within the last year, and the MET drugs that you've mentioned before, a couple of drugs approved maybe 18 months ago or whatever it is. So these are all new things that may not have been tested two or 3 years ago. So you need to really go back and look and make sure that they were covered.
That leads me to the next topic. Obviously, there are a lot of products available, a lot of publications that are looking at these. We've all got those 6 or 7 intensely rewarding patients. I've got 3 outpatients here in Kentucky. We probably don't see them as often because we're all smokers all the time. We don't have as many EGFRs and as we might see in the left coast. But as you start to move through this, I've been struck by one thing specifically with regards to some of the work that you've been doing recently. You are a really early adopter, I think, and probably maybe a little bit ahead of the rest of us in terms of your reliance upon liquid biopsy. I don't think I'm going too far to say that. It is something we are discussing weekly in our tumor boards. It's certainly the idea of sending plasma-based testing off is great because we don't have to pursue a second biopsy. Sometimes it's not reachable. Maybe I have 2 medical questions. One is, as you see correlation, has that field evolved to the point that your comfort levels are such that you don't think that you need a tissue and a plasma base? And then the follow-up to that might be, how often are you retesting during the evolution of your patient's resistance patterns?
Yeah, no, those are great questions. Yes. So, historically we've, held tissue as the holy grail. It's been the standard of care, and, you have to test tissue. It is incredibly important at all of your institutions that you get to your tissue procurers, those pulmonologists, the thoracic surgeons, the interventional radiologists, the primary care base, because you want to do the right thing first. We had a lovely discussion yesterday in Tumor Board about, in a complicated case that I won't bore you with the details, about how to get tissue. And, is it a VATS mediastinoscopy? Is it an EBUS? Is it also, we want to do one thing, and we want to do one thing that gets everything that we need as a medical oncologist. So we are doing better. It wasn't unusual 5-6 years ago for me to send a patient back for a second biopsy at the time of initial diagnosis. That is becoming much less common nowadays, and I think part of it is the ability to use plasma for testing. Now, plasma is complementary to tissue. Tissue in plasma, I think, are both standards. They're obviously very different. It's very easy to draw blood. You're right. We were an early adopter. I started probably somewhere around to 2012, 13-ish, with some pilot studies using it and incorporating it into clinical practice. And I think over the years since then, we've had several studies, the most recent of which is the Nile trial, which really, to me, cemented the clinical utility of plasma-based testing. And for those of you who don't know about the Nile trial, this was a very simple trial, 282 lung cancer patients, stage 4, that had biopsies, and their oncologists were told just to do whatever you normally do with testing tissue. And in addition to testing the tissue, we're going to do plasma-based testing on top of it. And the of the 282 patients, tissue found 60 targets, plasma found 77. The reason that tissue didn't find the targets either because there's tumor heterogeneity and you didn't find it, or more commonly, there wasn't adequate tissue to do the comprehensive testing, which is an issue because a lot of times you point out, Doug, a lot of times the biopsy is not easy to do. It's in not a terribly accessible place. Our patients do have anatomic variations that sometimes can make it difficult for biopsies to be done, and you have to put safety first and all those sorts of things. So tissue can be an issue, but plasma is not. Plasma is just a simple blood test, and we do have the technology nowadays where we know that tumors, and probably it has to do with a tumor burden, shed tumor DNA into the blood. You can detect it. And if you find something in blood, you can believe it and you can act on it, and you have the same outcomes, whether you find it in tissue or blood with targeted therapies. So to me, this has been one of the great advances in the practice of lung cancer, is the ability to use plasma-based testing to inform you about how to manage the patient. And the other great advantage of plasma is the turnaround time is significantly less, about a week or so, compared to tissue-based platforms, which are typically in the 2 to 3 week range. So there's a huge amount in my mind of clinical utility associated with these sorts of things. And, you asked the question about how often do you retest? Well, we kind of got spoiled with the initial EGFR story, because we were using drugs like erlotinib, gefitinib, afatinib, and these are first, second generation drugs. And we knew that the major acquired resistance mutation, T790M, emerged about a year later. We had a fantastic drug, osimertinib, that's a very good T790M drug. So after, say, erlotinib, you would see progression maybe 18 months later. You could test blood or tissue for T790M. If you found it, you could give them osimertinib, and it worked very well. In fact, that was the original FDA indication for osimertinib. And then the T790M story kind of fell apart because we started using osimertinib first line based on the Flora trial. So now T790M is really doesn't exist anymore because of osimertinib. But there are other things that exist. The resistance patterns to osimertinib are quite different and quite unfortunately heterogeneous in this setting. The one that emerges more frequently is MET amplification. And there are some drugs that are good MET drugs, and certainly studies ongoing, and certainly anecdotal case reports where, knowing that is informative, because you might add or replace treatment with a MET inhibitor nowadays. So retesting is important. It's easy to do by plasma. We also know that in these targeted populations like this, that sometimes there's histologic transformation. You can't identify that with a blood test. You have to do a tissue biopsy. So you have to use the clinical data in front of you. If a patient's with EGFR mutations is rapidly progressing, you have to be suspicious of histologic transformation to small cell. which is, or I've seen a couple cases of sarcomatoid carcinomas in this setting. So, you have to do a tissue biopsy to understand the histology, because it's going to really inform you to make a different treatment decision for patients. So that's important. But again, there's so many options nowadays in terms of how to think about patients in the tools that we have to manage patients. And again, getting back, I've said this many times, right treatment to the right patient at the right time. These are all tools that we didn't have 20 years ago that we now have to help with our decision-making process.
So it takes us back to the access issue, right? These are relatively expensive tests, and if you define these tissue markers or these plasma markers, then it leads to even more expensive treatments, $15,000, $20,000 a dose for some of these things. So we go back to Devon again, access. Mark and I love sending the tests. We send it as often as we can. I send it daily. I do retest quite a bit. I am finding increasing issues with coverage, and I know that's part of where you're spending your life now. Can you give us a current state of the science in 2021 for where we're headed in terms of advocacy and federal and state level support for coverage for these biomarkers? Obviously, Mark's made a compelling clinical case. Not surprisingly, sometimes the payers are not quite there yet.
Yeah, it's interesting that you bring up, in your discussion about comprehensive biomarker testing for lung cancer patients. And, just looking at some of the evidence out there, that is one area where we know that coverage is lagging for that comprehensive testing, particularly for the Medicaid population. Many states, many of their Medicaid programs lack, explicit coverage for comprehensive testing for lung cancer patients. And this is something that we've really taken on at ACS CAN, really first starting off by educating, lawmakers and policymakers why biomarker testing is so important. And I think Dr. Socinski just pointed out with his two stories that, when you biomarker test and there's a targeted therapy, this can be life-changing for so many patients. So I think the first step in the advocacy campaign is just telling those stories over and over again to lawmakers to really educate them on what biomarker testing is and how important it is, for cancer patients, and most importantly, how important it is going to be going forward across cancers as the technology, as the science continues to develop. So the first step is going to be, that education piece, and, breaking down some of those the next part is going to be breaking down those, barriers to coverage. And that's something that we've, been interested in here at ACS CAN, and we've developed model legislation that would, require state plans to cover, evidence-based biomarker testing for patients who need it. And luckily, we've had some early successes. There was recently a bill passed in Illinois a couple of weeks ago that starting in 2022, state regulated health plans are going to have to cover, biomarker testing for patients. So I really think, the first step is going to be that education piece, why it's so important to biomarker test, by continuing to tell those stories, and then really looking at where some of the disparities lie, particularly related to coverage, and also talking to doctors, talking to providers, and understanding, pushing to further understand what are some of the barriers that they're facing on their side of the coin, and just understanding what we could do to help providers test all of the patients that should be tested. And we've taken an interest in this as well. And actually last month, we launched a survey geared towards cancer providers, understanding some of the barriers that they may be facing to really use in our advocacy efforts going forward.
That takes me to future state, because that's I think where we start to really have our minds blown by what the science is evolving to. And I'm looking at right now, I've got a cholangiocarcinoma patient, Mark, that's progressed, and he's moving to an FGFR2 receptor antagonist. Maybe let's talk a little bit. We got about 8-10 minutes left. Let's talk about the future of this. So obviously we're increasingly enamored with the technologies available to us to target our therapies. It's been a game changer, both from a clinical standpoint and a patient standpoint. Where do you see this going next? I mean, this would have been inconceivable 10 years ago, what's going to be 10 years down the road that you're going to be handing off to your other future fellows that you're now training, the next level of Lieutenant Socinskis?
Yeah, I mean, I think, again, we're all, celebrating the advances that we've made. And both with immunotherapy as well as targeted therapies, and no one argues about the advance that we've made. We haven't talked much about immunotherapy, but the step up that we've seen with the use of PD-1, PD-L1 agents, a little early to know exactly the CTLA-4 story in lung cancer, how that's going to really add to the story. But we've seen such a step up in our options, in our survival outcomes. As I've mentioned again, in 2017 we had the greatest annual cancer mortality reduction, largely led by lung and melanoma. Now, the question is, what's next in the immunotherapy space? I'm not sure that we know. I think we'll be chipping away at trying to figure out, in the majority of patients, unfortunately, and I'll just make a point where, we recently saw the 5-year survival figures for KEYNOTE-024. KEYNOTE-024 was a trial that randomized patients who were high PD-L1 expressors, greater than 50%, to either pembrolizumab alone or standard chemotherapy. And at 5 years, the 5-year survival was doubled. So it was 16% on chemotherapy, 32% on pembrolizumab. And the fact that 1 in 3 patients was surviving 5 years is amazing in lung cancer. We just didn't see that before. I looked at that survival curve for the first time and I said, means 2 out of 3 patients aren't surviving. What's different about them, and what strategies are important to engage the immune system? Because the immune system is very powerful. I always remind patients that, someone puts the wrong kidney in you, mismatched kidney, your immune system is going to get rid of it. So you don't underestimate the power of the immune system. The question is, PD-1, PD-L1 is a great story because for many patients, or a strong minority of patients, their immune system is engaged, it's just silenced. And when you take that checkpoint away and you engage the immune system, we're seeing, I'll say it out loud, I think we're seeing cures of metastatic disease that we would never say in the chemotherapy era. We never say that, but I'm seeing it, and I'm beginning to believe it, that we do cure some patients that we felt 5 to 10 years ago were incurable. The question is, how do we engage more of that population? What are the next strategies to make what we like to call a cold tumor, where there's really no engagement of the immune system, to a hot tumor where the immune system may be there, it just needs to be pushed over the edge, and that suppression of the immune response by the tumor is taken away, and the tumor no longer has that advantage. And in the era of targeted therapy, again, I mentioned the ALK story, where we're now seeing that on the ALEX trial with alectinib, and the same is probably going to be true of with drugs like brigatinib and lorlatinib from the other trials that were done. We're seeing median survivals that are beyond 5 years, well beyond 5 years. And then the question becomes, why do patients become resistant in that? And what are the mechanisms that tumors use? As you well know, Doug, these tumors are smart creatures. Eventually they will figure out some sort of resistance pathway. And I think that's the next area where we need to focus on. There are ongoing clinical trials looking, for instance, at a number of different strategies in the EGFR space and other spaces that are designed to preempt the acquired resistance that we may see with targeted therapies and these sorts of things. So, it brings up the issue of everything we've talked about today has been done and learned through clinical trials. And it underscores the importance of doing good clinical research, doing good bench research, so we kind of figure out how cancer works, and learn how to best target it, but then translate that into, an appropriate clinical trial that shows us, guys like you and I and gals like you and I, who I always say, we have to close that door, walk into a patient's room, and that patient is hoping that we have something good to say and something good to do. And again, we've made this point many times, that nowadays, if my lady that I saw Tuesday ends up having, I'm betting she has an EGFR mutation. I don't know that yet, but I'm betting that she does. I've got a very good once a day pill for her to take that's going to be highly effective. That's great news for her. I just remembered her age. She's 77 and she's in great shape, but the convenience of taking oral medication that's highly effective is very, very rewarding for everybody involved in that. And so, we need to kind of continue that trend and figure out, how we make our gains even more meaningful for patients. It's very complex. I think it might be more complex in the immunotherapy space than it is in the targeted therapy space, but both of them, I think the next 10 years is going to focus on how to engage the immune system in a greater proportion of patients, and then how to deal with the acquired resistance that we see with targeted therapies at this point. So
it's fascinating. And now, man, we could have another hour on immunotherapy. I'm sorry we only have 35, 40 minutes for each of these, but that's a topic for another discussion. We'd love to have you back.
Yeah,
I do see the powers of these molecular testing moving to earlier stages.
yes.
Obviously we're seeing companies like Guardant and Exact Sciences and Thrive and Grail point that we might be able to detect reliably circulating tumor cells long before these things are visible on CT scans. And what's the role of an ALK inhibitor in a stage 1 resected cancer or a stage 0? If we find it in the DCIS equivalent in lung, we're getting to the point that the technologies are going to let us identify those.
Yeah, it's something we should mention that we haven't mentioned yet is the importance of lung cancer screening. We should be working just as hard on getting patients screened as we are working to get comprehensive genomic testing done. It saves lives. It saves as many lives as mammography and colonoscopy and all that kind of stuff, and probably more cost effective, at least the numbers that I've seen. And so, if you meet the criteria, you should be screened. I think I saw some numbers, having recently done a talk where I had to address some of the issues in the lung cancer screening area, that in the state of Florida, if you looked at, I forget the name of the database that will tell you, how many patients would fit the criteria for lung cancer screening, no matter which, guidance body you use there. Only 20% of the patients in the state of Florida who would presumably be eligible for lung cancer screening are getting screened. So again, there's a message there about early detection makes a difference. And we should also say, if you don't smoke, don't start. And if you are smoking, please quit, because it will help reduce the burden of lung cancer. Although, 30 to 35,000 US citizens who have never touched a cigarette will still get this disease on an annual basis. Getting rid of smoking won't get rid of lung cancer, but it'll change the face of lung cancer.
I think we can leave it there. It's fascinating stuff. And I really appreciate both of your perspectives, because it's clear that with what Dr. Socinski does and what he's done over the last 30 years, we're moving the bar for all of our patients once we have access to these things. And on the ACS CAN side, and the work that Devon and his colleagues are doing is trying to make sure that everybody has equal access to that. And obviously we can't leave people behind. You can't have a worse prognosis because of the color of your skin or your zip code, or whether you're a Medicaid patient, or whether you have language barriers, or the other things that ACS CAN and the legislative arms are trying to address from a disparities standpoint. So I guess from Dr. Socinski and I to you guys, Devon, it's critical. It's for those of you that are cancer fighters on here that do this for a living. If you're talking to your state legislatures, if you're talking to funding, if you're on the pharma side and you can help educate clinicians, more patients win when we're doing more biomarker testing. So I think we're out of time. I've gone over. Sorry, Christy Young. Thank you for hosting us again, ACS Can. Thank you, Dr. Socinski, for guiding a lot of my career. I've watched you many, many times, and it's always an exciting thing to see what's happening inside your head. A little spooky sometimes, but it's a treat to share it with you. So for those of you that joined us today, hope you've learned a lot. Hope you leave engaged and enthusiastic about where we're taking these fields. And we'll see you back next month for our next installment. And thanks for joining.